class, and remaining diseases will be in this class. The next topic is facial palsy, paralysis, MND, GB syndrome, myasthenia gravis, Parkinson's disease, SLE, MS, and MD will be discussed here. First disease is facial palsy, which is very close to the disease Ardita, which is mentioned in our class 6. In facial palsy, the cause is the damage of facial nerve, that is the seventh cranial nerve, that supplies the muscles of face. It can be categorized on the location into two, on the basis of location into two: central facial palsy and peripheral facial palsy. In the central facial palsy, due to the damage of damage caused above the facial nucleus, and in the peripheral palsy, the damage is below the facial nucleus. Coming to the etiology, it is not so defined. Etiology is not clear, idiopathic, and it can be linked with the viral infections like herpes virus, and tumor. That anatomical structural problems like tumor, it can be a common cause in facial palsy. The tumor can compress the facial nerve, and it can cause facial paralysis. And the facial palsy during the surgical removal of any tumor, and less common tumors to cause facial palsy include cholestoma, hemangioma, etc. Usually not due to the tumor. Usually while removing the tumor, facial nerves are getting affected. Infections, Ramsay Hunt syndrome, Lyme disease, etc., are the common cause for facial nerve palsy or facial palsy. Iatrogenic facial nerve damage occurs most common temporomandibular joint replacement, mastoidectomy, and paroidectomy, etc. Congenital causes are there, and some rare causes of facial palsy are neurosarcoidosis, otitis media, multiple sclerosis, GB syndrome, etc. And risk factors: those who are having diabetes, or are pregnant, or having such diseases, potentially risk diseases, ear infections, upper respiratory tract infections, obese persons are at high risk for causing facial nerve palsy if they met with the etiology. Coming to the diagnosis or understanding the disease signs and symptoms: appearance and range of movements, inability to close the eyes. This will be the first noticed symptom. Inability to move lips. They will be unable to smile or hold the water inside. Inability to move the lips or hold the lips. A drooping of face may be noticed. The person is synkinesis. Synkinesis is if you move one part of the face or organ, another part will be moved. That is called a synkinesis. The affected side of mouth may sit higher than the affected side, than the unaffected side. Affected side will of mouth sit higher than the unaffected side. Facial synkinesis, I mentioned earlier, it can be defined as the abnormal facial movements that occur during the volitional or spontaneous movement. For example, voluntary movement of the mouth may result in the closure of eye. A part of face is voluntarily moved, and involuntarily another part is moved. That is, closure of or movement of uh, lip can cause the closure of eye. Ectropion can cause the ectropion can be seen in the facial nerve paralysis. Functional effect: difficulty in eating, drinking, etc., and lack of lip seal, closing the lip seal will be affected or lacking. Difficulty to keep the fluid inside or food in the oral cavity. That is very noticeable symptom or noticeable functional defect in the facial nerve palsy. And in case of pronunciation or speech, labial consonants will be very difficult, or there will not be clarity while pronouncing the labial consonants like I, E, B, etc. And dryness of affected side, eye will be seen. Some somatic effects in the palsy are the facial nerve supplies the lacrimal glands, so and salivary glands, and it's also transmit the taste from the anterior two-third of the tongue. Facial nerve is supplying anterior two-third of the tongue, so sweet taste is perceived from the anterior two-third of the tongue, and that will be affected in facial palsy. Facial paralysis often involve lack of tear production in the affected eye. That is previously mentioned, dry eye will be there, and that can lead to the corneal ulceration later. There are two factors contribute to dry the eye in facial nerve palsy. That one is greater petrosal nerve, and second one is the zygomatic branch of facial nerve. These two nerves affecting, and that can result in the symptoms of eye, especially the dry eye. Hyperacusis is the sensitivity to sudden loud noise that can be seen in facial palsy. Altered taste sensation will be seen. This is the picture showing the affected. Left side is affected with facial palsy. Diagnosis can be made from the history, taking an examination. All the nervous system examination can be done completely, especially central nervous system examination. Audiogram can be conducted. Nerve conduction studies, neuronography (ENOG) can be done. CT, CT or MRI can be done. EMG can be done. In treatment, steroids and antiviral drugs. Usually, as I said in the beginning or the etiology, usually viral infections are the cause for facial nerve paralysis. So antiviral drugs, and for an immediate effect, corticosteroids are administered. These are the drugs example for antiviral drugs. Valacyclovir or acyclovir is used. And surgery, decompression surgery, facial nerve compression will be occurred due to any cause, and that surgically removing the compression. Decompression surgery can be done. Plastic surgeries are done very rarely. Facial reanimation surgery can be done, including the eyebrow lift, drooped eyebrow, eyebrow can be lifted, eyelid lift, facial implants and nerve grafts, etc. are done as facial reanimation surgery. These are the treatment modalities or treatments in the or observed in the facial nerve palsy. Next is paralysis. Paralysis is very commonly known as Pakshakada or can be directly connected with Pakshakada. And not only Pakshakada, we have some diseases like Ekanta Vada, Adhakaya Vada, Sarvanga Vada, etc. This also can be connected with paralysis. We will see how it can be connected and how the symptoms are connected. You can see the picture and footnotes mentioned in the picture. First, monoplegia, hemiplegia, diplegia, paraplegia, quadriplegia. These are the types of paralysis. Very simply classifying or for a simple understanding, these are monoplegia is ekangavada, one side on or one part is affected. Hemiplegia is Pakshakada, one Paksha is affected. Diplegia, Ardhangavada, half part is affected. Paraplegia also, Ardhangavada, half part is lower half is affected. Two limbs are affected. Quadriplegia is completely four limbs are affected. Quadriplegia, four limbs are affected. That can be connected with or correlated with Sarvangavada. Based on this area affected, this is classified, and the terms are used: hemi, para, quadri, etc. Hemi refer to half part of body. Para is both legs. Quadri for all limbs. This is the nomenclature for paralysis or types of paralysis. This based on the area affecting. This is causes of paralysis. Different part of brain or nervous system is affected, and depending on the part affected, the symptoms will vary, and that is the causes also determined based on the area affected. Upper motor neuron cortex In cortex, ischemia can be happen, hemorrhage, and intrinsic mass lesions or extrinsic mass lesion can be happen. Intrinsic mass lesion due to the primary or metastatic cancer or abscess, etc. Extrinsic mass lesion can be seen due to can be occur due to subdural hematoma, and also degenerative cause. Cortex in cortex, degenerative causes can be seen. The major causes ALS, amylotropic lateral sclerosis, and in subcortical white matter or in internal capsule, there are also ischemia, hemorrhage, intrinsic mass lesion due to cancer of, or abscess, immunological causes like multiple sclerosis, we will be discussing later, infectious cause, progressive multifocal leukoencephalopathy. That infectious cause can cause subcortical damage, and in brainstem, ischemia and immunological example is multiple sclerosis, spinal cord, extrinsic compression can be seen, like in cervical spondylosis, metastatic cancer, etc. Immunological cause like in multiple sclerosis, transverse myelitis, etc. Infections, especially AIDS. You can see this kind of lesions, and there can cause paralysis. Nutritional deficiency can affect the spinal cord. Nerve degeneration can be caused due to the nutritional deficiency. Motor unit, in the motor unit, spinal motor neuron, they cause mainly degenerative, as mentioned earlier, ALS, infectious like poliomyelitis, in spinal root, compressive like degenerative disc diseases, immunological like GB syndrome, infectious like AIDS and Lyme disease, peripheral nerve, motor unit, peripheral nerve, metabolic causes will be the diabetes mellitus, uremia, etc. Toxic causes, toxins like heavy metals or ethanol or any other drugs can cause nutritional deficiency, vitamin B12 especially. Usually in neurological conditions, first line of treatment, they will be modern, in the modern science will be supplying vitamin B12. Nutritional deficiency can cause nerve damage, especially B12 deficiency. Inflammatory diseases, polyarteritis, and hereditary causes can be there. Immunological causes will be there. Infectious causes will be there, causing the peripheral nerve damage. Then neuromuscular junction, immunologic causes will be there like myasthenia gravis. Toxic causes will be there like botulism, and muscles affecting inflammatory conditions like poliomyelitis, associated with poliomyelitis, degenerative condition like seen in muscular dystrophy. Toxic conditions can be in the toxic condition, and in infectious condition, muscle damage can be seen. How to identify or clinical features of paralysis varies according to the affected site and connected areas. Depending on the part affected, or depending on the area affected in the brain or central nervous system, the clinical features vary. The clinical features shown on the respected paralysis area will be seen. And this the most common paralysis symptom is loss of muscle function in one or more part of body. Loss of muscle function will be noticed first. The patient will be unable to use the muscles, like movement of limbs, or an inability to lift the weight or hold the objects like that can be observed first. Numbness or pain in the affected muscles can be seen. We have seen in the last class neuralgia, neuropathic pain, that will be noticed, that will be seen in the patient. Muscle weakness will be there, visible signs of muscle loss, muscle atrophy, wasting will be seen, stiffness of muscle can be seen, involuntary spasm or twitches can be seen in the muscle. How can we diagnose? Of course, history taking and examination are important. X-ray, MRI, CT, myelogram, etc. can be done. Nerve conduction study and electromyogram (EMG) can be conducted for the diagnosis. Especially MRI and CT will be effective, and other examination findings are very relevant in case of diagnosis of paralysis. Treatment, as per modern science, there is no cure or no permanent cure for paralysis. According to the cause of paralysis, the treatment is planned. If it is infection, It can be done. If it is compression, decompression therapies or measures can be done. And if it is due to the toxicity, toxins can be removed, detoxification can be done, or any anatomical or structural problem that can be removed according to the cause of paralysis. Depending on the cause of paralysis, the treatment can be planned. Physical, occupational, and speech therapy can be done in the paralysis case. Physical therapy, physiotherapy can be done. Occupational therapy, the patient can be taught to the some skilled work, depending on based on his abilities, or uh, avoiding his disabilities, how can he perform some activities. That kind of occupations can be included in occupational therapy. Speech therapy will be very effective because speech loss will be there in paralysis. Speech therapy can be very effective. Some exercises can be done. These are the supportive therapy. Rehabilitation services can help the people with all type of paralysis. They should enjoy, or they should spend the life, the remaining life, with some quality, with maximum possible quality. The quality of life can be improved in the maximum possible way. That is the aim of treatment. Not only modern medical science, other system of medicine like Ayurvedic system, in our system of medicine is very effectively treating paralysis. And the muscle weakness of muscle can be changed, or can be treated, and the muscle strength can be attained by our Ayurvedic therapies. Also, acupressure, chiropractic care, etc., are having a very good role in regaining the strength of muscles, or making or bringing back the patient to maximum possible uh, previous maximum possible way to to spend his life very in a qualitative way. So improvement the quality of life, improving the quality of life is the main aim of treatment, and that can be achieved very effectively through Ayurvedic medicine. And other systems of medicine can be incorporated, like acupuncture therapy, chiropractic, etc. And prosthetic equipments can be used for the better quality of life. Supportive equipments can be used for improving the quality of life. Surgery can be done if it is clot, or as I told, some anatomical or structural problems are there. If it can be removed by a surgical procedure, that can be done. Or nerve repair, or like surgery can be done if it can serve better to the patient. Next is motor neuron disease, MND short, and it is known as MND. All part of body is affected, and so it can be correlated, or it can be considered as Sarvangavada. Motor neuron disease is an uncommon condition that affect the brain and nerve. It causes the weakness that can worse over the time. It is very progressing in nature. UMN and LMN lesions are seen. Upper motor neuron and lower motor neuron symptoms, lesions are seen. As per modern science, there is no cure. There is no cure for motor neuron disease, and MND can significantly shorten the life expectancy. The patient may not live for a long time if he is affected with the MND, and it can lead to death also. Amyotrophic lateral sclerosis (ALS) is the most common form of progressive motor neuron disease. This is a different type of sporadic MND. Sporadic MND means not having any familial causes. That is those MND are grouped under sporadic MNDs. The chronic MND, upper and lower motor neuron are there. Predominantly upper motor neuron is a type, and predominantly lower motor neuron. And amyotrophic lateral sclerosis, primary lateral sclerosis, multifocal motor neuropathy with conduction block, motor neuropathy with paraproteinemia or cancer, motor predominant peripheral neuropathy can seen. Other types of sporadic MNDs, like associated with other neurodegenerative disorder secondary motor neuron diseases, and acute conditions like infections, poliomyelitis, herpes zoster, etc. This is this may be very familiar to the Ayurvedic people, or not only Ayurvedic people, medical field, human lesion and element lesion. The major differentiating factor in human lesion and element lesion are the muscle tone will be increased in the human lesion and tone will be lost in the element lesion. Power, there will not be any loss of power, that is power will be intact in human lesion, power will be lost in the element lesion. Reflexes will be exaggerated in the human lesion and reflexes will be diminished or lost in the element lesion. In Babinski sign will be positive in human lesion, Babinski sign will be negative in the element lesion. Clonus will be present, clonus will be present in human and clonus will be absent in element lesion. Paralysis, spastic paralysis can be seen in human and flaccid can be seen in element lesion. These are the very evident and very clear differentiating factors which can be observed in the patient. Causes and investigation, different causes. How can we find the different causes by or through some through the investigations we can perform. The diagnostic category, we can see structural lesions. How can we identify the structural lesion? As we can, as very clearly, we can find out the structural lesion by radiological investigations like MRI scanning. MRI of it can be done to find out the structural lesions. Structural lesions like cervical spondylosis, parasagittal or foramen magnum tumors, Kyrie malformation of syrinx, etc., can be seen in the MRI. By the investigation, we can see. How can we diagnose or how can we and understand the infections? Bacterial infections can be there, viral infections can be there, retroviral infections can be there, tetanus, polio, herpes, myelopathy, etc. This can be identified by the blood and CSF examination. CSF can be trained and CSF can be done for a culture. That can be that can give a clear idea about the infectious organism which caused the disease. Antiviral antibody can be done. HTLV1 titers can be done. These are the investigations done in the to find out the infections, especially CSF examination. Intoxication, physical agents like toxins, drugs, electric shock, X-ray radiations, etc., can be diagnosed by 24-hour urine sample can be used for heavy metals, or toxicity can be identified by the examination of urine which is taken 24-hour sample. And blood test can be done, serum level of lead or serum level of toxic substance can be done based to understand the toxicity in the body. Immunologic mechanism can be identified by performing the blood investigations, blood count, complete blood count, sedimentation rate, total protein, etc. And MRI scan, bone marrow biopsy, etc., also can be performed. And metabolic causes can be identified by the particular investigations regarding related with the metabolic disease. Hypoglycemia, hyperparathyroidism, hyperthyroidism, deficiency of vitamin, as I mentioned earlier, B12 vitamin deficiency, deficiency of minerals like copper, zinc, malabsorption will be there, mitochondrial dysfunction will be. These are the common causes of metabolic uh, causes, common metabolic causes that can be identified by fasting blood sugar examination, routine chemistries including calcium, parathyroid hormone, thyroid function test, vitamin B12, and vitamin test in the blood, serum, zinc, copper, etc. 24-hour stool fat examination, carotene, fasting lactate, pyruvate ammonia. These kind of investigations can help us to identify the metabolic causes. Hyperlipidemia can be identified by the lipid electrophoresis. Hyperglycinuria can be identified by urine and serum amino acid, CF amino acids, CSF amino acids, etc. Hereditary disorders can be identified by the DNA analysis. These are the investigations, probable investigations, and through that investigation, what are the findings or what are the conclusions we can reach. Principal features of UMN and LMN lesion, we already have discussed. No muscle wasting. In UMN lesion, no muscle wasting will be there. Spasticity will be there. Clonus will be present. Brisk tendon jerks are there. Extensor plantar reflex Babinski sign will be there. Absent abdominal reflexes. No fasciculations. No fibrillation potential in EMG. These are the features, principal features of UMN lesion. And in LMN lesion, marked muscle wasting or atrophy will be there. Flaccidity, hypotonia will be there, hence given the name flaccid paralysis. No clonus will be there. Opposite to the UMN, whatever we have seen and opposite to the UMN, there will be seen in LMN lesion. Diminished or absent tendon reflexes, absent plantar reflexes, absent abdominal reflexes, fasciculations may occur, fibrillation potential present in the EMG. These are the cardinal features or differences which can be observed in UMN and LMN lesion. The signs and symptoms of MND, it happened gradually and may not be obvious at first. Early symptoms can see weakness in the ankle or leg. Blurred speech will be noticed, which may develop into difficulty in swallowing some food. That can be affected later. Weak grip will be noticed later. The items will be the holded items will be dropped down from the hand, and I find hard to open the jar or do up buttons, putting the buttons, and jar or bottle opening will be difficult. Muscle cramps and twitches will be there. Weight loss will be there. Arms or legs muscles may have become thinner over the time. That can be observed. Difficulty uh, difficulty stopping oneself from the crying or laughing in the inappropriate situation. That is later that can be seen and in the beginning stage. In later stages, complete paralysis may happen. Paralysis of respiratory muscles if occur, that can cause the death. So this is the later and complicated stage we can see in MND. Laboratory investigations, as already mentioned in different areas, electromyogram EMG can be done. CSF can be checked. Muscle enzymes like CPK or CK can be done. That will be elevated. Several types of secondary motor neuron disorders that resemble ALS are treatable, and therefore all patients should have the careful search on all these diseases. So investigation, we should not we should not neglect the investigation. We should always go for laboratory investigations or uh, radiological investigations to the possible extent for a proper diagnosis. MRI, CT myelography is often required to exclude the compressive lesions of foramen magnum or cervical spine. When involvement is restricted to the lower motor neurons only, another important entity is multifocal motor neuropathy with conduction block. The treatment of motor neuron disease, here also there is no definite cure or treatment for MND, but treatment can help to reduce the impact of symptoms on a patient's life. Occupational therapy, like as mentioned in the paralysis, can we have seen the paralysis, that can help to the patient to lead a good or quality life. Physiotherapy exercises can strengthen the muscle and reduce the stiffness. Speech and language therapy can be done. Proper diet can be done. Ayurvedic therapies will be very helpful. Sneha Sweda procedures will be very helpful to reduce the stiffness and also improve the movement. And speech therapy, say Murdhini Daila, etc., can be done. That can improve the quality of neurological functions. And very important thing is emotional support. We should support the patient. We should motivate the patient for his activities. The occupational therapies thereby help to improve the quality of life. And motivation, Sattva can be done. Sattva can be done for the patients having this kind of chronic diseases. Next, we will move on to the GB syndrome or Guillain-Barre syndrome. Adhyavada, Medasavardavada, Sarvangavada. We cannot connect it into a single disease, or it is difficult. As per disease GB syndrome, the stages are different, and different symptoms will be seen different, can be understood as different diseases in Ayurveda. Treatment also vary depending on the symptoms and depending on the stages of disease. GB syndrome is a rare but a serious disease which is caused by a post-infectious immune-mediated neuropathy. It results from the autoimmune destruction of nerves in the peripheral nervous system, causing symptoms such as numbness, tingling sensation, weakness, and this disease can be progressed to a paralysis, a dysfunction of muscles. It can be leading and end up with a dysfunction of muscles, and can end up with a paralysis if it is happening. The paralysis or dysfunction of musculoskeletal system, muscle system happening in the vital organs, that can lead to the death, especially in the lung and cardiac muscles. Exact cause of GB syndrome is not known. That is why it is called as idiopathic. GB syndrome can cause due to the infections. It can cause due to the infections. Immune mediated neuropathies, post infectious, etc., are considered to be the cause of GB syndrome. So immune response, if it is triggered to fight the infection, and it can lead to a cross reaction to the host nerves, and that can lead to this disease. These are the common infections that can cause GB syndrome. Many infections linked with GB syndrome, they can trigger the disease. Actually, it is not clear that whether these infections can cause GB syndrome, but if the patient is susceptible for the disease, and this infection susceptible for GB syndrome, and this diseases can trigger the disease, and it can lead to the disease in future. Most commonly, this influenza virus, cytomegalovirus, Zika virus, COVID, hepatitis A, HIV, mycoplasma pneumonia, etc., are said to be the cause for GB syndrome, or has said to be the triggering factor for GB syndrome. Rarely, the vaccinations can trigger GB syndrome. Influenza vaccine and COVID-19 vaccine. COVID-19 vaccines, some scientists opine that COVID-19 vaccine can cause GB syndrome. There are some cases reported even in our country. In India, some cases are reported GB syndrome occurred after the vaccination, COVID-19 vaccination. But some other scientist opinion that is that COVID-19 vaccination will not cause GB syndrome. So even there are some dilemma regarding the COVID-19 and GB syndrome. Any kind of vaccination can trigger the immune system, or can hamper the immune system, and that can lead to GB syndrome, because any triggering factors, a person who is susceptible for GB syndrome, any triggering factors can lead to the disease. So COVID-19 vaccination uh, can be, if even though it is very rare, it can be a triggering factor for GB syndrome. These are the types of GB syndrome: AIDP, acute inflammatory demyelinating polyneuropathy. And the symptoms of AIDP are sensory symptoms and muscle weakness will be there, often cranial nerve weakness and autonomic involvement will be there. And the nerve conduction studies show demyelination. And next type is acute motor axonal neuropathy, AMAN, acute motor axonal neuropathy. Isolated muscle weakness will be seen without sensory symptoms, less than 10%. Cranial nerve involvement is very uncommon. In the previous thing, cranial nerve weakness is involved. ADP in AMAN, there is rare involvement of cranial nerve. The next type is acute motor and sensory axonal neuropathy, AMSAN. Severe muscle weakness will be there, similar to AMAN, but with sensory loss. Sensory loss will be evidently seen in this. In nerve conduction study, axonal polyneuropathy can be seen. The fourth type is pharyngeal cervical brachial variant. Weakness of particularly of the throat muscle, face, neck, etc. Shoulder muscles are affected. Miller-Fisher syndrome is another thing. Ataxia, eye muscle weakness will be there. Areflexia. Areflexia means absence of reflex. Deep tendon reflex is called areflexia. That can be seen in Miller-Fisher syndrome, but usually no limb weakness seen in the Miller-Fisher syndrome. In nerve conduction study, generally normal. Generally it will be normal. NCS will be normal. Sometimes discrete changes in sensory conduction can be seen. These are the types of disease, GB syndrome. And the signs and symptoms of GB syndrome. In general, GB syndrome patients describe the fulfillment of course of symptoms that can usually include ascending weakness and non-length dependent sensory symptoms. Ascending weakness is the particular feature seen in GB syndrome, from lower part to upward, that will be seen in the GB syndrome. Ascending weakness is one of the cardinal feature in GB syndrome that should be noticed. Symmetrical involvement is another key feature of GBS. Symmetrical involvement is if it is lower limb, if it is affected up to the thighs or up to the knee, and both side will be affected. Symmetrical involvement is there. And relapsing or remitting a course at presentation would be considered atypical. And GB is often present within 1 to 6 weeks of antecedental illness. So if it is if the person is exposed to a cause or triggering factor, within 1 to 6 week, the patient present with the symptoms. Surgery, trauma, or other infections, whatever can be an antecedental illness. GB syndrome often begins with tingling and weakness starting from the legs. Tingling sensation of leg or weakness of legs will be seen in the first. Later, it is spreading upwards to the body, and it can affect the upper limbs also. In about 10% of the disorder, symptoms begin in the arm or face. Usually, it begin in the lower limb, and in some cases, in 10% of cases, it can be begin in the arms or face. Prickling, uh, pin needle sensation in the fingers, toe, ankles, etc. can be seen. Weakness in the legs that can spread to upper body, that is ascending weakness mentioned earlier. Unsteady walking or instability to walk or climb stairs will be seen. Difficulty in facial movements including speech, chewing, swallowing, etc. can be seen. In later stages, double visions or inability to move eyes can be seen. Severe pain that may feel aching pain, achy pain, shooting pain, or cramp-like pain can be seen, and the pain can worsen at the night. Difficulty with bladder control and bowel control can be seen. Incontinence can be seen in the GB syndrome progressed stage. Rapid heart rate will be there. Low or high blood pressure can be seen. Difficulty in breathing can be seen in GB syndrome. Uh, the difficulty of closing eyes, that this can be seen in the GB syndrome. How can you diagnose, or what are the investigations to be done in GB syndrome? It is difficult to diagnose in the earlier stage because we have seen the tingling sensation and some mild weakness of lower limbs, etc., are the seen in the beginning stage. It can be a symptom of any diseases, or even without any disease, peripheral nerves can be affected, and peripheral nerves can be irritated, and that can cause this kind of symptoms. So very difficult to diagnose in the earlier stages. If you can diagnose in the earlier stages, can be progression can be slow down. Progression can be slowed down. Cannot be arrest the we cannot arrest the progression, but can make the progression very slow, especially with our Ayurvedic treatments. History taking and physical examinations are very important as in other diseases. Electromyography and nerve conduction studies, NCS and EMG, can be done. Spinal tap, lumbar puncture can be done to identify, to find out any other infectious causes, or to differentiate from other diseases. MRI can be done. A negative inspiratory force, NIF, is done for diagnosing the disease. Next is treatment management. As the previous diseases, this is also a non-curable, incurable disease. There is no cure for GB syndrome, but two type of treatment can speed the recovery and reduce the severity of illness. That the progression of weakness can be arrested, or the progression of weakness can be slowed down by the treatment. That is the aim of treatment, especially intravenous immunoglobulin injections, IVIG. IVIG is the intravenous immunoglobulin injections that can be done, that uh, can help to arrest the further damage, and that can help to prevent the spread of weakness. Immunoglobulin containing healthy antibodies from the blood donors is given through vein intravenously. High dose of immunoglobulin can block the damaging of antibodies, and that may contribute to the GB syndrome. This is the principle behind IVIG. Plasma exchange therapy, that's plasma pheresis, can be done in GB syndrome is act by removing the pathogenic antibodies, humoral mediators, and complement protein involved in the pathogenesis of GB syndrome. That is the principle behind plasma exchange or plasma pheresis therapy. Other therapies include corticosteroids, analgesics for symptomatic relief, physical help, and physical therapy. That is, say, emotional therapy, etc., can be done. In Ayurveda, if it is, you can see, if it is a symptom of avarana, first we have to treat for removal of avarana or amapachana, especially this is a vadavyadi, but can be associated with the kapha or ama or Medas, etc. Avarna or association will be there. For that, that should be removed. Avarna should be removed. Amapajana should be done. Then Brahmana therapy should be done to strengthen the muscle or to prevent the weakness. This is the principle where we should adopt in the GB syndrome. There are many institutions in India. They treat such kind of diseases, GB syndrome, multiple sclerosis, myasthenia gravis, etc., in a very effective and very good manner. They're treating with Ayurvedic principles. So there is a scope with Ayurvedic therapy in such type of diseases. Next is another type of disease in the same way, myasthenia gravis, Vadavyadi, Dhadukshaya, Kabhanabandhavada, Sarvangavada. These are the possible or probable understanding of myasthenia gravis. Anyway, here also Vada, the Vaigunya Vada Dushti is there. Usually associated with the kapha, probably associated with kapha or avarna. That should be removed first and treated for vada in the later stage. This is the principle of understanding of myasthenia gravis, understanding and treating the myasthenia gravis. We will see how what is myasthenia gravis. It is an autoimmune neuromuscular disorder resulting in the weakness and fatigability of skeletal muscles due to the due to the autoantibodies directed against the acetylcholine receptors at neuromuscular junctions. This is the definition of disease. This is the cause of disease is follows. Autoimmune cause: immune system produce antibodies that can block or destroy many of the muscle receptor site for acetylcholine, and that can result into the disease. The commonly implicated protein in neuromuscular junctions against which autoantibodies are produced include the nicotinic acetylcholine receptors, muscle specific kinase, and lipoprotein related proteins. These are the pathology expected or supposed to be. This is the pathology happening there. Some people have myasthenia gravis that isn't caused by antibodies blocking acetylcholine. This type of myasthenia gravis is called as seronegative myasthenia gravis. As we seen in rheumatoid arthritis, there will not be a rheumatoid factor in the blood. Seronegative rheumatoid arthritis in similar way. If antibodies are not detected, it is called as seronegative myasthenia gravis. Then congenital myasthenic syndrome, hereditary form of myasthenia gravis, is called as congenital myasthenic syndrome. We will see the types of myasthenia gravis. Early onset myasthenia gravis, depending on the onset age. The early onset myasthenia gravis below the age of 50 year. Thymic hyperplasia will be seen. Usually seen early onset is seen in the females. Late onset myasthenia gravis onset is after the age of 50. Thymic atrophy will be there, mainly seen in males. And thymoma associated myasthenia gravis. Myasthenia gravis with MuSK antibodies, and ocular myasthenia gravis OMG, ocular myasthenia gravis in symptoms only affecting the extraocular muscles. Myasthenia gravis seen in or the symptoms affecting only on the ocular muscles, extraocular muscles, that is called as ocular myasthenia gravis. Myasthenia gravis with no detectable AChR and muscle specific tyrosine kinase antibodies. This is another type which cannot be included in any of the above symptoms, that is grouped in the last heading. It's a clinical classification. It is used in the clinical diagnosis and treatment. Class 1 classification is seen. Class 1, any ocular muscle weakness, possible ptosis, no other evidence of muscle weakness is class 1. Class 2 is muscle weakness affecting other than ocular muscle. Ocular muscles are affected and another group of muscles are affected. Class 2A, predominantly affecting the limb, axial muscles, or both. May also have lesser involvement of oropharyngeal muscle. Class 2B is predominantly bulbar and or respiratory muscles. May also have lesser or equal involvement of limbs, axial muscles, or both. Class 3, moderate weakness affecting other than ocular muscles, may also have ocular muscle weakness at any severity, that is class 3. Class 3A is predominantly affecting the limb, axial muscles, or both, may also have lesser involvement of oropharyngeal muscles. Class 3B is predominantly bulbar and or respiratory muscles, as seen in the class 2B, and may also have the lesser or equal involvement of limb, axial muscles, or both. Next is class 4. Class 4 is severe weakness affecting other than ocular muscles, may also have ocular muscle weakness at any of any severity. Class 4A is predominantly affecting the limbs, axial muscles, or both, may also have lesser involvement of oropharyngeal muscles. Class 4B is predominantly bulbar and or respiratory muscles, may also have lesser or equal involvement of limbs, axial muscles, or both. Can also include feeding tube without intubation. Class 5 is intubation is needed to maintain the airway. The muscles are completely weak and completely lost the function, and to maintain the airway, intubation is required with or without any mechanical ventilation. Mechanical ventilation may be required or otherwise may not be required, but intubation will be required in such cases. Class 5. This is a classification 1 to 5, and sub classifications where there are 2 3 classes. And signs, and we will move on to the signs and symptoms of this disease. Usually initial complaint is a specific muscle weakness rather than the generalized weakness. Frequently in ocular symptoms, we have seen in all types of mg, we have seen ocular muscles are involved. So first ocular muscles will be involved. Generalized weakness may not be there. It will be specific weakness of ocular movement. Frequently ocular symptoms will be there. Extraocular muscle weakness or ptosis is present initially in 50% of the patient and occurs during the course of illness in 90% of person. Only for 50% we can see in the beginning stage. Other patients in the later stage. 90% of patients will have the extraocular symptoms in the later stage. The disease remains exclusively ocular in 10 to 40% of the patients. They will not get affected with any other group of muscle involvement. 10 to 40% of myasthenia gravis will be exclusively affecting the ocular muscles. Rarely the patient have generalized weakness without ocular involvement. As I said, ocular involvement is the first sign, or first involved muscle is ocular muscles, extraocular muscles. But very rarely the patient will express the disease or exhibit the disease in the form of general weakness without ocular muscle weakness. Eye muscle weakness are often symmetrical and variable. Bulbar muscle weakness is also common. Facial muscle weakness can result in trouble smiling or trouble whistling, expressionless face, etc. Symptoms like difficulty in chewing or frequent choking, dysphagia, hoarseness of voice, and dysarthria can also be seen. Weakness tend to spread from the ocular to facial to bulbar muscle and then to trunk and limb muscles. This is the way of progressing weakness. First affecting the ocular muscle, then to facial muscles, bulbar muscles, then to truncal muscles, and later on the limb muscles. With the weakness of neck flexors more common, and neck extensor weakness is very rare to present. Limb weakness may be more severely proximal than distally. Proximal muscles are more severe than the distal. Isolated limb muscle weakness is the presenting symptom in fewer than 10% of patients. The isolated limb muscle weakness can be seen in less than 10% of the patients. Weakness is typically least severe in the morning and worsen as the day progresses. In the morning, after a resting period, it will be a less severe symptoms, and the day progress or the work progresses, the symptoms will get worsened. Weakness is increased by exertion and alleviated by rest. Increased by exertion. Whatever, if the patient is doing some activities or work, the symptoms will aggravate, and the symptoms will subside when he or she take rest. Weakness progresses from mild to more severe over weeks or months with exacerbations and remission. Exacerbations and remissions can be seen, and the disease will be progressing over the time progresses. Less often, symptoms may remain limited to extraocular and eyelid muscles for many years. The symptoms may not progress for many years to or will not spread to another group of muscle for long years. That can be seen. Previously, we have seen 10% of patients may have exhibit with only ocular muscle weakness, or later, after years after, that can spread or progress to another group of muscle. This is the picture representing the disease. Smoothing out of forehead, eyebrow, drooping of eyebrow, drooping of corner of mouth can be seen due to the weakness of muscle. Respiratory muscle weakness develop up to 40% of the patient, and myasthenic crisis. Myasthenic crisis is the respiratory failure. The group of muscle, as I told, it is progressing from the ocular muscle to facial muscle and to the limb muscles. During the progress, if it is affecting the respiratory muscles, that can cause the respiratory failure. That condition is called as myasthenic crisis. Present about 15 to 20% of patients with myasthenia gravis. It is the complication seen in the patients with myasthenia gravis. Diagnosis and investigations, detailed history taking and physical examinations can be done. Serological investigations, blood tests can be done with anti-AChR antibody test is very specific. Also check for the anti-MuSK antibodies, anti-LRP for antibodies, imaging techniques like CT scan or MRI, electrophysiological tests like RNS test, single fiber electromyography can be done, and endophonium test can be done. These are the investigations done for the disease myasthenia gravis. Management, cholinesterase enzyme inhibitors are done. Immunosuppressants are given. Corticosteroids are also given for the symptomatic manage or suppressing the progression or preventing the progression. IV intravenous therapies like plasmapheresis, we have discussed in previous disease also. Intravenous immunoglobulins are administered. IVIG are administered. Monoclonal antibodies are administered. These are the treatments mentioned in myasthenia gravis. Some type of surgical treatments also can be done. Thymectomy is done. If there is having a tumor in thymus gland, thymectomy can be done. This is video assisted thymectomy and robot assisted thymectomy are available. This we have completed the disease myasthenia gravis, and we will move on to another disease. It is very important, and it can be very uh, frequently seen in Ayurvedic clinical practice. Parkinson's disease. This is not Kambavada is direct correlation of Parkinson's disease, but it is not mentioned anywhere in the Brihatrayi or Laghutrayi. It is Basavarajyam, Kambavadam, Karapada Tale Kambo, Deha Brahmana Dukhide, Nidra Nashto Madikshena, Kambavada selection. It is mentioned there in the textbook. That very typically seen in Parkinson's disease. Parkinson's disease is a neurodegenerative disease that disorder that mostly present in later life with the generalized slowing of movements. Bradykinesia will be there, and at least one or other symptom of resting tremor resting tremor or rigidity. Other associated features are loss of smell, sleep dysfunction, mood disorders, excess salivation, constipation, and excessive periodic limb movement in the sleep. Parkinson's disease usually first noticed symptom will be the tremor will be there. That is the cardinal feature of Parkinsonism is also this tremor and difficulty in movement. That is bradykinesia will be there, salivation, excess mood disorders, sleep dysfunctions, loss of smell, etc. can be associated with. The causes of Parkinson's disease. Parkinson's disease is a disorder of basal ganglia, which is composed of many other nuclei. The stratum receives excitatory and inhibitory inputs from several parts of cortex. The key pathology is the loss of dopaminergic neurons that lead to the symptoms. Dopaminergic neurons, loss of dopaminergic neurons are the major cause which is seen in the Parkinson's disease. The condition is caused by the slow deterioration of the nerve cells in the brain, which create dopamine. Dopamine is a natural substance found in the brain that plays a major role in our brains and body by messaging and therefore communicating across various systems. So these communications will be affected or damaged by the deficiency of dopamine. How this is causing use of pesticide, herbicides, and proximity to industrial plants. So this is the industrialization is happening throughout the world. Industrialization is happening. So pesticide and industrial waste, chemicals, etc., are increasing in our atmosphere and nature. So this is affecting the people, and that is why the prevalence of disease is increasing. And after injection of MPTP, this chemical accumulate in the accumulate content. That is another cause. Oxidation and degeneration of free radicals causing the damage of thalamic nuclei that can cause PD. Genes, the risk of Parkinson disease in sibling is increased if one member of the family has this disorder. So familial or genetic involvement is clear in this disease, in Parkinson's disease. The altered function of uh, alpha-synuclein may play a role in the etiology of Parkinson's disease. Young adults rarely experience Parkinson's disease. Young adults are rarely experiencing the Parkinson's disease is related with the etiological factor related with age. Next, we will move on to the signs and symptoms of Parkinson's disease. Parkinson's disease, the signs and symptoms can be different for person to person, patient to patient. It can vary. Early signs may be uh, mild and go unnoticed. The earlier symptoms may go unnoticed, and once the disease is progressed, and the patient will be noticing and approaching the physician. Symptoms often begin on one side of the body and usually remain worse on that side even after the symptoms begin to affect both sides. One side will be affected first, and that can be progressed without affecting. It may not affect the other side, and it can progress on the single side. Tremor is the major feature. Tremor shaking movements usually begin in the limb, often hands or fingers, usually in the fingers. That is what I told. First symptoms will be the tremor, especially in the fingers, or especially in the fingers, usually in the limb, can be upper limb and lower limb. Patient may rub thumb and forefinger, pin rolling movement, pin rolling tremor. This is called known as pin rolling pill rolling tremor, like rolling the pills. Pill rolling tremor will be there. The hand may tremble when it is at rest. This is the feature, the nature of tremor seen in Parkinsonism. After using the hand, such as picking up of a book, the tremor may vanish or for some minutes. If some activities are done, the tremor may vanish for some time, only to return when the patient is distracted and to end the resting on again. This is the so-called re-emerging tremor that is a typical feature of Parkinson's disease. Although the tremor is prominent and early symptom of Parkinson's disease, it is not always present and is not a necessary feature of diagnosis. That is a very important thing. Usually, tremor will be there, but there is Parkinson's disease, or there are patients with Parkinson's disease without tremor. So that cannot be considered as a cardinal symptom to diagnose Parkinson's disease. Slowness or bradykinesia will be there. The patient may walk in a very slow manner, and their ability to respond to threats is compromised. Patients demonstrate an inability to tap their index finger and thumb rapidly. ask the patient to tap the thumb to index finger rapidly, then the patient will be unable to do it, and rhythmically they not follow the rhythmicity, and they cannot walk steadily. These are the features seen in Parkinson's disease, that slowness and or bradykinesia, under the heading slowness or bradykinesia. Rigidity is the third predominant or dominant feature seen in the Parkinson's disease. Patients appear stiff and they find it difficult to rise out of a chair without support. Getting up from a chair will be difficult for the person with Parkinson's disease because of stiffness. In the treatment of Parkinsonism, usually dopamine is supplied, and that syndopa can also cause stiffness. Even in the disease Parkinsonism, stiffness is a symptom, and in the treatment method, if you supply syndopa, that can also cause the stiffness. So this rising difficulty in rising up from the chair can be seen in the patients with Parkinsonism due to the disease or due to the effect of the medicine. Parkinsonism is typically asymmetric at the onset. As I told earlier, one side will be affected and that can be progressed, that can get progressed. Later, the other side can be affected. Micrographia is another feature, diminishing the size of handwriting over time. The patient will be writing letters in a smaller size. This is called as micrographia. This picture, if you notice this picture and you capture this picture in your mind, is very easy to understand the Parkinson's disease. Stooped posture, masked facial expression is the one major feature of Parkinsonism. Rigidity will be there. Forward tilt of trunk. The walking is called as the walking to catch the gravity. So the center of gravity, it seems to be like the patient is walking to catch the center of gravity. The typical posture seen in the picture like this, reduced arm swinging. Usually we will walk with swinging of arm. The swinging of arm will be reduced in the patients with the uh, Parkinson's disease. Flexed elbow and wrist will be there. See, you can see in the picture very typically flexed arms and wrist. Slightly flexed hip and knees. Slightly flexed hip and knees can be seen. Trembling of extremities will be there. Shuffling and short stepped gait. Short stepped gait is another main feature of Parkinsonism. They cannot walk with the long steps. They can only walk with the short steps, and seems to be catching the gravity. Center of gravity. We look the patient as they are going to catch the center of gravity. That kind of walk will be there in the patient. So the posture, the tremor, the flexed elbow and wrist, and the nature of walking, short step gait. These are the features. Only this picture is enough to understand the symptoms of Parkinson's disease. And the gait disturbances will be there. And as I told, flexed posture. And in advanced Parkinson's disease, there will be slow step gait and unable to stop themselves from falling. That is seen in the progressed cases. Autonomic symptoms are common in Parkinson's disease. Constipation, difficulty in swallowing, urinary retention, erectile dysfunctions are common. Constipation, rolling of saliva, mood disorders, and depression can be seen. Diagnosis and investigation, detailed history taking, imaging techniques like MRI, and specific laboratory investigations are not there, but dopamine can be tested. That dopamine transporters can be done particularly for the disease, but Parkinson's disease. Blood test can be done to rule out other diseases. This is the very accepted scale for uh, assessing the severity of Parkinsonism, Hoyne and Yar scale. And this is classified into stage 1, stage 1.5, stage 2, stage 2.5. say stage 3 and stage 4. That is same in the seen in the picture. In the stage 1, unilateral involvement. In the stage 1.5, unilateral with axial involvement. Stage 2, bilateral symptoms. No impairment in balance. Stage 2.5, there mild bilateral disease with the recovery and pull test. Mild to moderate disease, physically independent. Stage 3, severe disability seen in stage 4, still able to walk or stand. Stage 5, completely on wheelchair. This is the classification of Hoehn and Yahr. This is scale for assessing the severity of Parkinson's disease. There is no permanent cure for Parkinsonism, but carbidopa, levodopa, etc. are given. Dopamine and agonists are given for the treatment. MAO inhibitors can be given. Catechol O methyl transferase COM inhibitors can be given. Anticholinergics can be given. These are the medications given in the treatment of Parkinson's disease. Surgical deep brain stimulation is done as a surgical method to treat the Parkinson's disease. In Ayurveda, the dopamine supplements like Kapikechu, Ashwagandha are used. That Masha is used. Masha Atmagupta Dikashaya is used. Masha, Ashwagandha, Masha, Kapikechu are the major drugs which contain dopamine, and it can be effectively used in the treatment of Parkinsonism. And all other therapies which can alleviate vata can be used. The Sneha Sweda, etc. can be used in the treatment of Parkinson's disease. Next is SLE. SLE can be very clearly seen as the symptoms of Vata Rakta. First, skin manifestation will be there. Later on, the progressively affecting other tissues. Systemic lupus erythematosus is the most common type of lupus. SLE is an autoimmune disease in which the immune system attacks its own tissues, causing widespread inflammation and tissue damage in the affected organs. This is called as SLE. Cause of SLE still, as other disease, it is unknown. Still, some theories says genetic factors, environmental factors like ultraviolet, medications, virus, etc. can cause. Sex hormone factors can cause the disease. This is the theories regarding the causation of SLE. Signs and symptoms: 90% of patients are women, usually of childbearing age, more common in the blacks than the whites. This is worldwide prevalence in constitutional signs and symptoms like fatigue, fever, malaise, weight loss, etc. can seen. In the skin manifestation, the butterfly rash, especially malar rash, that is seen. Malar rash is seen in the as a cutaneous symptom. Photosensitivity will be there. Vasculitis, alopecia, oral ulcers, etc. can be seen. Later on, it progresses with arthritis, inflammatory, symmetric, non-erosive arthritis. Hematological symptoms like anemia, etc. can be seen. Cardiopulmonary symptoms or manifestations will be there in the later stage of SLE. Nephritis can be seen. Gastrointestinal symptoms, neurological symptoms, hair thinning, mucous membrane ulcer. It can affect any type of tissue in the progressing stage. Especially first, it can be begin with the skin or mucosa. Later, it can affect any system, any organ in the progressing stage. Diagnosis can be done by the history taking and physical examination. Presence of ANA is a cardinal feature, but it cannot be considered as a typical one. Appropriate radiographical studies can be done, ECG can be done, urine analysis, chest X-ray can be done. These investigations are aimed to find out the progress of disease or where it is affected to, or it is affected to which extent. This is the picture of SLE butterfly rashes. Management is and its treatment is based on the severity of disease and the symptoms. It is the aim of treatment is to control acute severe flare to develop maintenance strategies whereby symptoms are suppressed. Suppression of symptoms and flares of disease. Sudden increase of symptoms are called as flares. It should be suppressed or managed with medicines. Treatment choice depending on whether the disease is life threatening, whether the manifestation are reversible. These criteria are taken before going to a treatment. Conservative therapies for non-life threatening diseases, NSAIDs are given for symptomatic relief. Anti-malarial drugs, HCQs, are given. Some other diseases, lymphocyte stimulator, etc., are given as a symptomatic or based on the pathology. For life-threatening SLE, the systemic glucocorticoids, steroids are administered to uh, catch the patient from the catch back the patient from the death. Glucocorticoids are used to treat the serious type of SLE. Immunosuppressants also are used. These are the modern pharmacology. It's not required in detail. It can be given as notes. Next, we will move on to the multiple sclerosis. Multiple sclerosis is a disease which is affecting, it is Vadavyadi, which is affecting the Majjadhatu especially. Or it is also an autoimmune disease of the central nervous system characterized by chronic inflammation, demyelination, gliosis, and neuronal loss. The cause may be relapsing and remitting or progressive in nature. Lesions in the CNS occur at different times and in different CNS locations. Because of this, multiple sclerosis lesions are sometimes said to be disseminated in time and place. Multiple sclerosis is seen, it can affect, the symptoms can be seen all over the body. The exact etiology of MS is not known. Multiple sclerosis, exact etiology is not known. Factors involved in the pathogenesis can be grouped under three categories: immune factors, environmental factors, and genetic factors. This immunity with an autoimmune attack on the central nervous system is the leading hypothesis on hypothesized etiology of multiple sclerosis. Family history is one of the if any of the siblings are affected, or the family history is there, other persons are having high risk of developing the disease. Multiple sclerosis, regarding the on based on the age or regarding the age, multiple sclerosis can occur at any age, but onset usually occur around the 20 to 40 year of age. Some infections, a variety of viruses can be linked with the multiple sclerosis. Vitamin D levels can be related with the multiple sclerosis. Low exposure to sunlight are associated with greater risk of multiple sclerosis. Certain other autoimmune diseases also can trigger, like psoriasis, pernicious anemia, thyroid disorders can also trigger the disease. Smoking is another contributing factor for the disease. Categories of multiple sclerosis, the category based on the disease course. Based on the disease course, this is categorized. This can be identified or diagnosed after the symptoms manifest, or on after observing the course of symptoms. First one is relapsing and remitting. 70 to 80% of multiple sclerosis are relapsing and remitting, RRMS group. It can be symptoms last for 24 to 48 hours, that can develop over days or days to week, after a gap of 1 week or 2 week, or if after a gap of some days it can recur. This is relapsing and remitting type. Primary progressive type, multiple sclerosis, PPMS. 15 to 20% of the patients present with a gradual deterioration from the onset with an absence of relapse. Secondary progressive multiple sclerosis, SPMS. This is characterized by a more gradual neurological deterioration after an initial RR course. The superimposed relapse can be a feature of this clinical course as well, although this is not mandatory feature. The fourth type is progressive relapsing. Only 5% of the patient can be seen under this group. Gradual deterioration with superimposed relapse can be seen. Another three categories, the following three categories are sometimes included in the spectrum of multiple sclerosis: clinically isolated syndrome, fulminant, and benign. These are the another three categories to be included, can be included in the multiple sclerosis. Signs and symptoms of multiple sclerosis are onset may be abrupt or insidious. Some patients have symptoms that are so trivial that they may not seek medical attention for months or years. Most common are recurrent attacks of focal neurological dysfunctions. Symptoms often transiently worsen with fatigue, stress, exercise, or heat. Ataxia, tremor, dysarthria may reflect the disease of a cerebellar pathway. Uh, I have recently had came across with a patient with multiple sclerosis. She is of age 30 and she had the symptom of imbalance while walking and some difficulty in vision. So they consulted with the ENT specialists many times, and they have done all investigations related with ENT, and this management treatment also done for that, and that was not subsided, and they came for Ayurvedic management, and I just suspected this disease and sent for an MRI, and this that shown the evident features of multiple sclerosis. Once it was diagnosed, the patient's symptoms were subsided by the Ayurvedic mode of therapies. But later on, they consulted allopathic treatment, and they done for interferon therapies, etc. And still, the patient is having symptoms, but in a mild way. They are continuing both Ayurvedic and modern therapies. So this can be manageable. We cannot say this can be treated with Ayurveda or this can be treated with modern medicine, but can be manageable to extent. If combined therapy effectively done, it can be treated. These are the symptoms. The picture shown the symptoms based on the location in the body. Manifestation of multiple sclerosis as protein, but commonly include the weakness or loss of sensory symptoms involving the limb. Visual difficulties will be there, as I told in the same patient. Visual difficulties are the first was the visual difficulty was the first symptom. Urinary urgency or frequency can be seen. Can present as heavy, stiff, or weakness of motor muscles. Tingling sensation will be there. Pin and needle will sensation or dead sensation will be seen. Optic neuritis can result in blurred vision. Optic neuritis can be seen in the later stages of multiple sclerosis that can lead to the symptoms like blurring of vision, diplopia, nystagmus, vertigo, etc. Diagnosis based on clinical presentation. Two or more attacks, no diagnosis will be done. Two or more attacks, objective clinical evidence of lesions, that MRI can be, the very evident MRI can be done, and in MRI we can see the evidence of multiple sclerosis. And attacks, the clinical evidence, two or more lesions will, if it is there, then that also can be done with for MRI can be done, and a follow-up MRI can be done, and you can wait for another attack, then we can go for any investigations. These are the usually some one time symptoms will be there in one episode, and if it is not there, usually we will not go for any symptoms, and repeatedly symptoms are there, we can go for investigations like MRI, or one or two symptoms in less frequency, we can wait for another episode, we can send for the symptoms. Investigation that CSF can be taken for cultural diagnostic purpose. MRI can be done. Evoked potential test, visual, auditory, somatosensory test can be done to identify the lesions or the multiple sclerosis. Urodynamic studies uh, can can help to find the symptoms of bladder. There is in case of treatment, there is no cure for multiple sclerosis. Treatment typically focus on speeding recovery from the attacks, slowing the progression of disease. This is the aim of treatment. And corticosteroids, plasma exchanges are done to reduce the progression or to arrest the progression. This newly emerging or new therapies like interferon treatments are the injectable interferon treatments are there. These are very not very common in practice, but in modern system, injectable interferons are using to arrest the progression of disease, not to arrest and can slow down the progression of disease. Oral treatments can be oral medications can be given. These infusions can be given. Muscle relaxants can be given to for a symptomatic relief. Medications to reduce fatigue. These are the symptomatic management which can be used for the treatment of this disease. And psychological symptoms like depression, if it is there, it should be treated. Depression, if it is there, it should be treated with the antidepressive therapy or psychological psychotherapies, etc. to be done. Then another disease, the next disease is muscular dystrophy. In this also, dhadukshaya will be happening. It's a typical type of Vadavyadi. And this can be understood by the uh, tissues, dhatu involved. In muscular dystrophy, the term muscular dystrophy incorporates an uh, assortment of hereditary disorders that lead to progressive generalized disease of muscle prompted by inadequate or missing glycoproteins in the muscle cell plasma membrane. Causes are genetic causes, dominant gene, recessive gene, genetic causes are there. Also, depending on the age, disease also classified in different types. The types of muscular dystrophy, you can see Duchenne's muscular dystrophy, Becker muscular dystrophy, congenital MD, limb girdle MD, like fasciculo, uh, sorry, this another myoclonic muscular dystrophy, these are the types of muscular dystrophy. We can see on each in detail. Duchenne's muscular dystrophy is X-linked recessive mutation of the dystrophin gene that can be seen. And next, Becker muscular dystrophy, single gene defect will be there. Limb girdle muscular dystrophy, autosomal recessive chromosome. These are based on the etiology. Distal congenital oculopharyngeal autosomal dominant. Signs and symptoms. Most common type of muscular dystrophy we see in our clinical practice is Duchenne's muscular dystrophy. Most common form. Frequent fall will be there. Difficulty in rising from lying or sitting position. Patient will get up or from sitting to standing position by the help of hand. Trouble running and jumping will be there. Waddling gait will be there. Walking on the toes will be seen. Large calf muscles. Pseudo hypertrophy of calf muscles can be seen. Muscle pain and stiffness will be there. Learning disabilities can be seen. Delayed growth can be seen. These are another types of muscular dystrophy, not much common. Becker muscular dystrophy. Signs and symptoms are similar with Duchenne's muscular dystrophy, but tend to be mild and progress more slowly. This is the characteristic feature. Myotonic is characterized by inability to relax the muscle following the contraction. Once it is contracted, it's very difficult to relax. FSHD, it can be seen. Muscle weakness typically begins in the face, hip, and shoulders. It is onset is usually in the teenage, but it can be in the later age also. Congenital can be affect the boys and girls in apparent at birth before the age of 2. Some form progress slowly and can cause only mild disability. Limb girdle can be seen especially in hip and shoulder muscles are usually affected. This limb girdle muscular dystrophy is affecting for hip and shoulder muscles in the beginning. People with this type of muscular dystrophy might have difficulty in lifting the front part of foot and so might trip frequently. Onset usually begins in the childhood and in the teenage. This is limb-girdle muscular dystrophy. And these are you can see in the table the symptoms, age of onset, affected muscles. This already mentioned, and it is given in the tabular form for easy understanding. You can see later in the notes and or in this PPT. This are what are the symptoms previously mentioned are grouped in this table. These are the pictorial representation of affected Duchenne's muscular dystrophy affecting these areas, and the different types limb-girdle affecting. These are the areas depending on the areas affecting. This classification or pictorial representation is given. Then we will see how to diagnose the disease. Enzyme tests are done. Genetic map, gene mapping or genetic test, gene tests are done to understand. Muscle biopsy is done. Heart monitoring tests, electrocardiography and echocardiograms are done to check whether heart function is affected. Usually in muscular dystrophy, the problem or the complication is due to cardiac muscles or respiratory muscles. So this should be diagnosed or understood to prevent an emergency. So genetic test can be done, muscle biopsy can be done, enzyme test, especially creatine kinase. If you are suspecting a patient having muscular dystrophy, first suggest for a creatine kinase. If CK is elevated, then you can go for another following test or to understand whether to which extent it is affected. Lung monitoring test, as cardiac symptoms mentioned, lung monitoring tests are also important to check the lung functions, because I told it is an emergency if it is affecting the cardiac muscles or lung muscles. Electromyography and to be done to test the muscles. EMG usually done in all kind of neuromuscular or muscular degenerative disorder. EMG can be performed. It's based on electrical activities. And in muscular dystrophy, the treatment, coming to the treatment of muscular dystrophy, there is no treatment for muscular dystrophy. Still, like other diseases, the progression can be prevented, or the progression can be arrested, or the activities, physiotherapy or any therapies which can strengthen the muscles and extend the uh, uh, quality of life, which can be done for the patient. Steroids can be done, given. Cardiac or respiratory, if it is affected, such medications can be given. Movement exercise, mainly exercises and supportive mechanical aids, mobility aids, breathing assistance, etc., are to be provided depending on the symptoms or depending on the severity or depending upon the muscles group of muscles affected. Surgery might be needed to correct the contractures or spinal curvatures. If it is there, surgery can be done. These are the specific treatments for different type of muscular dystrophy in the major line of treatments. These are the medications mentioned for different types of muscular dystrophy. And in Ayurvedic therapy, we can give as we can consider it as a Vadavyadi and Snehasveda can be done, but any times it can be association. There can be Ama or Kabha association or Meda association will be there. So in such stages, we should go for a Avarana treatment or Pajana line of treatment or Shodhana, mild Shodhana therapy, then followed by Brahmana therapy, continuous treatment. Snehasveda continuously to be given, which can be in intervals, which can be treated with the Pajana or Shodhana therapy. Uh, to an extent, the quality of life can be improved, or not improved, can be maintained to an extent for patients with muscular dystrophy. So the modern topics are almost over, but there are many diseases. There may be many diseases that can be understood based on different diseases. These are the main major disorders we completed under the Vadavyadi. Okay, thank you.